Currently, the SERDs fulvestrant and elacestrant are only used to treat metastatic breast cancer. But is there a place for them in the treatment of early-stage breast cancer? The current standard of care for early estrogen receptor-positive breast cancer consists of initial local therapy, which is typically some combination of surgery and radiation. Patients then receive adjuvant hormone therapy for 5 to 10 years, depending on their risk of recurrence. This adjuvant hormone therapy regimen of tamoxifen or aromatase inhibitors has remained the standard of care for more than 20 years. Patients may also receive chemotherapy or a CDK4/6 inhibitor called abemaciclib during this time if they are at high risk of recurrence. We spoke with medical oncologist Dr. Priya Rastogi about ongoing clinical trials that are taking a new approach by using oral SERDs in early estrogen receptor-positive breast cancer.
With these trials, we have EMBER-4, which is evaluating imlunestrant. So imlunestrant is a oral selective estrogen receptor degrader, and it specifically targets and binds to the estrogen receptor and induces a change that results in degradation of estrogen. So it prevents the estrogen-mediated signaling and inhibits both the survival and growth of estrogen expressing cancer cells. So EMBER-4 is a phase 3 study evaluating imlunestrant versus standard endocrine therapy in the adjuvant setting. So this is after patients have received standard care and then I have been on endocrine therapy for at least 2 to 5 years, then the randomization is to imlunestrant versus to continue on standard endocrine therapy. So this trial is for patients with hormone receptor positive, HER2 negative, early stage breast cancer with an increased risk of recurrence based on both clinical and pathological features. Another study is the lidERA study. So this is evaluating giredestrant. So giredestrant is also a highly potent oral estrogen antagonist and degrader. And so lidERA is a phase 3 trial evaluating adjuvant giredestrant versus standard endocrine therapy in hormone receptor positive HER2 negative early stage breast cancer. So again, patients have finished their standard local, regional, and potentially systemic treatment, and then are randomized to giredestrant versus standard endocrine therapy. Patients who are eligible for the trial, again, have either intermediate or high risk breast cancer. We then have camizestrant, which is also an oral potent SERD and a pure estrogen antagonist. So we have 2 studies in the early stage setting that are evaluating camizestrant. There's Cambria-1 or NSABP-B62, which is evaluating camizestrant versus standard endocrine therapy for 5 years. So patients who are eligible for this study have received at least 2 years of standard endocrine therapy, but up to 5 years of standard endocrine therapy. So patients have had their standard treatment and then have been on standard endocrine therapy for 2 years, but up to 5 years. Patients are then randomized to camizestrant versus continuing standard endocrine therapy for 5 years. And again, patients must have intermediate or high risk. So in this trial, patients continue for 5 years on either treatment, whether it's camizestrant or endocrine therapy. Cambria-2 is an upfront study. So in this study, patients must have completed definitive local regional therapy with or without chemotherapy for intermediate or high-risk disease. And in this study, patients are randomized to camizestrant versus standard endocrine therapy. And then the planned duration in Cambria-2 is 7 years of treatment in either treatment arm. Patients, again, must have intermediate or high-risk disease.
Dr. Rastogi discussed the 2 different approaches the Cambria trials are taking, testing oral SERD camizestrant in early estrogen receptor positive breast cancer. The Cambria-1 trial is testing the effectiveness of starting camizestrant after 2 to 5 years of standard hormone therapy, and the Cambria-2 trial is testing the effectiveness of starting camizestrant upfront. Both trials are comparing these regimens to the current standard of care. Dr. Rastogi explained how these 2 approaches are meeting the unmet needs of patients.
It's really exciting that with the Cambria trials, we have them in 2 settings within early stage breast cancer. So for Cambria-1, patients are randomized to receive either the camizestrant or hormonal therapy up to 5 years, but this is after completing at least 2 years of standard endocrine therapy. So this study is assessing if patients receive some standard endocrine therapy and then switch to a different therapy, will this improve outcomes? So patients can sometimes develop resistance while on endocrine therapy, and so a switch to a different endocrine therapy may improve outcomes. So Cambria-1 is evaluating if camizestrant will be better in terms of efficacy and safety for extended adjuvant therapy compared to standard adjuvant endocrine therapy. Cambria-2 is for patients intermediate or high risk for recurrence. These patients will be randomized up front to receive either standard endocrine therapy or camizestrant for 7 years. So patients again have their standard local regional therapy, chemotherapy if needed, but then at that point they're randomized to camizestrant or to standard therapy. So this upfront study is assessing whether starting an oral SERD versus receiving standard endocrine therapy will improve outcomes. Cambria-2 then is evaluating camizestrant for efficacy and safety in the adjuvant therapy compared to standard endocrine therapy for patients with hormone receptor positive, HER2 negative early stage breast cancer.